Thank you so much. So there are 4 concepts to be discussed today. And the process is each concept is assigned to a council member. The assigned council member will summarize the concept, then comment on its importance to NACNR's mission, and then make any additional comments. After the remarks, the floor is open for comments by council members. So the first concept is palliative care in home and community settings. And this concept is assigned to Dr. Kathy Bowles.
All right. Thank you. Take good care of me. This concept is titled Palliative Care in Home and Community Settings. And the purpose of this concept is to support studies aimed at determining needs and best practices for the integration of palliative care in home and community settings. So that broadly said, as you read on down through the concept paper, I feel that this concept has been very well defined. It's very broad and includes a lot of important components, such as trying to address issues in communication, social isolation, assisting with caregiving needs, and evaluation of function within the home and community-based settings. They're looking for evidence to support appropriate screening and assessment tools. So it starts at the beginning of what is palliative care, how can we screen people for the need for it, to determine who would benefit from earlier referrals to the programs, as well as who would benefit the most. So I thought that was very comprehensive in how they focused on that. Understanding the needs and how to meet the needs of those receiving the services. It also looks at diverse populations, ethno-cultural communities, rural and urban. So really thought of everything I felt as I walked through this, underlining, different dimensions of it. They want studies that personalize care plans that address individualized goals and preferences, and even include technology. Which cross-cuts across a lot of the NACNR priority areas. They're looking to measure individual and family-centered outcomes, and also pairing it, that must be paired with information on healthcare utilization and costs. And the second 2 objectives of this concept would look at some implementation science aspects. So how would we then successfully adapt these interventions and implement them into local systems? So again, from the start of the measurement, the screening, the building of interventions, the evaluation of that in a broad way, allowing the use of technology, and then advancing it into practice through implementation science, I thought was very comprehensive. The only 2 things that I noticed that I did not notice in the write-up was a focus on the role of nursing in palliative care in home and community settings. I think that a lot of the delivery of this could occur in the home care setting by skilled home care nurses, and so there was not a mention of the role of nursing. And also symptom control was not specifically mentioned. And the transition to hospice was mentioned for people who do not require hospitalization but are not appropriate for hospice. But I thought that the opportunity for palliative care in the home and community-based setting might be to identify those who would benefit from hospice either now or shortly thereafter. And so perhaps the transition to hospice might be within there with the terms of when appropriate. At the bottom of the file, you'll see 3 objectives, and those are overall a gestalt of this concept analysis or paper concept is to describe the gaps, barriers, and essential elements of comprehensive palliative care in the home and community settings, to test and evaluate the palliative care models and interventions that are theoretically based and designed with the goal of translation and implementation into community settings, and then to translate effective home and community-based programs across geographic and regional areas with attention to factors that require tailoring for broad dissemination and implementation. And so that was the objective I felt that covered like an implementation science aspect of this. And that's my summary.
Thank you so much.
You're welcome.
So any comments from you? We are looking for your feedback.
So the other thing that I didn't notice was a focus or an incorporation of the caregiver in the home. And I think that's particularly difficult. Not only how do they get appropriately used within that setting, but also how do we maintain their health and their self-efficacy during that time, which can be difficult. And I also think that caregiver, we need to be thoughtful that it's not just those that have a formal relationship, like a spouse or a parent, but also those like girlfriends, partners, those that don't have that legal relationship. And how do we share information about the person, the patient, appropriately with that? Those are my thoughts.
Thank you. Yes.
If I could just expand upon what Kathy said, that nursing isn't in it, but I would expand it to include nursing-led teams. So as community health workers, I think are going to play a bigger and bigger role in care in the future. They're often directed by nurses. And there are some public health models that might be applicable here where nurses have key leadership positions.
Any other comments? Okay.
If I could, let me back up. If you mind, before you
Okay, I forgot something, so I apologize. I jumped into the concepts really quickly without explaining to those who are our guests and others in the room that what the concepts are. So just give me a couple of sentences here. So each year, our council members are asked to review the concepts that we have spent a large amount of time creating and refining. It's a process, and we hope that these concepts will actually become future initiatives. The development of the concepts is a deliberative process, so we have a science planning meeting. Dr. Catherine Bowles actually attended that. Thank you very much. It was changed, the date was changed, otherwise we would have had another council member there as well. At the science planning meeting, each of the proposed concepts are discussed. We talk about them similar to the way we do here and refine them. Then we bring them here at a council meeting to give all council members an opportunity to weigh in and provide further insight into this. Personally, I think as we become more interprofessional and looking at teams, I think it really takes multiple viewpoints to shape these concepts. So we appreciate everyone providing insight from their perspective on this. Now.
Thank you. So the next concept is patient activation for self-management of chronic illness. And this is assigned to Dr. Moore, that is Shirley Moore.
Okay. So in this concept, I want to point out that the title is Self-Management of Chronic Illness, which has been NINR's focus. But those of us in the field often want to say there's also self-management of health and health promotion. And I think patient activation could be linked with that as well. Helping people engage in healthy behaviors for weight management, that sort of thing, just to stay healthy. So the concept here, first of all, there's a very good description of why this is an important concept in terms of managing chronic illnesses and engaging patients to having patients engaged in that and serve as partners to work with those of us. So the need for it is well done. It's linked to self-management is well articulated here. The construct itself, there's the definition of it here is that it's an indicator of patients' knowledge, skills, abilities, and willingness to manage their health and health care. I'm thinking that one of the things that we would need to emphasize are closely related concepts. Okay. Are closely related concepts. How does this differ from motivation? How does this differ from self-efficacy, from self-regulation? There are many processes in self-management that I think are very close to this. And I think we need to start sorting those out, because right now we throw all of them in our models and we measure all of them and they're highly correlated. So it's suggesting some backup work that might be needed just on the concept itself and its measurement. The write-up talks about the highly cited theory that's out there that actually puts people in 4 levels. That's, I think, I just want to emphasize, that's only one theory about it. And I worry a little bit. I think the stages of change model has not served us particularly well in advancing science, just putting people in a category and our attempts to try and match interventions to those categories. So I worry about following that model exactly here. I think it'd be interesting to emphasize, although it talks about looking at patient demographics and health literacy, there's the word cultural and patient preferences does not occur in it. And I think when it comes to having people engage, have a willingness to not just be observers of the health, but to engage in it, that there's a lot of cultural underpinnings to that. And so I think that we should encourage studies that deal with that. I think also, putting out a call more science to be developed about how does patient activation differ from one chronic illness to another? Is it this trans concept, or is it very different if it's diabetes versus self-management following an acute, a more event that it's not as chronic? So I think that would be an area that we might want to look at. Another comment that I had was that it seems to be an assumption through here that this is a behavioral concept. And I think we may want to look at some of the physiologic mechanisms behind it. I just know in my work where I'm looking at brain phenotypes and people's behavior associated with how they how they respond to different types of information, is suggesting that there may be some brain phenotypes, there may be some hormonal phenotypes that are involved here, stress composites of markers that are involved in terms of people's taking action on behalf of themselves. I'm not sure it's all just a beliefs behavior model. And so I would suggest that there be encouragement to look at a fuller model than just the behavioral, but also think of some physiologic or physical components as well. There's a strong thing here that I like a lot about examining interventions that will increase patient activation. Again, along with that, I would hope that we look at the mechanisms of those interventions along the way. Tailoring is mentioned, but again, I'm going to suggest that we make sure we get the word cultural and patient preferences in there. So anyway, the final call is for the suggestion is that objectives would include testing interventions, looking at how we might tailor, looking at, it says psychosocial factors. I think we might want to go beyond that. In fact, we may even want to list a few, like the role of anxiety, depression, loneliness, or something, many of the social ones there. Lastly, the potential collaborators has NIA and NICHD. My experience is NIDDK and Heart, Lung, and Blood Institute are two that also do a lot of adherence self-management research, and there may be others. Those just popped into my mind. So,
Thank you. So we will reach out to other ICs as well. So thank you. Thanks for the suggestion. This is open for the discussion.
I think the power of this is that it can be applied to so many health issues. And I do HIV research, and there's a big initiative that's just been announced, the End the HIV Epidemic initiative, that's going to involve NIH and CDC and SAMHSA and bunches of players with the aim of really driving HIV incidence down to zero through two main approaches. One is early diagnosis and treatment of people with HIV, and the other is PrEP uptake. Both of those, the thing that's going to determine whether this works is going to really involve self-management and activation. And I think that there's a real applicability of this to this other initiative as well. Because unless we can get people engaged, healthy people to take antiretrovirals in the case of PrEP, or people with hugely disenfranchised lives to adhere to antiretroviral regimens for the rest of their life and be virally suppressed, that initiative can only work. So I think this is really pertinent to many timely issues, including that.
Thank you so much. Thanks for that comment. Yeah, hi.
So Dr. Moore helped us out. We had a summit on how to manage back pain among active duty military members, and one of our key gaps is that there's not a whole lot of literature out there on self-management. And it's not just fix your own back, but it's really how do you strengthen those muscles and how do you do all of that. And I think this is really a key element, not just for, some diagnosable conditions, but also just in terms of health and in terms of managing pain, that I think is really critical. And I almost feel like our discussion earlier about precision health, that perhaps this provides a little bit of a foundation to be able to tailor or be more precise with how we help people manage their own, whatever that is, whatever they need to manage. Just my thoughts.
Thank you.
Well, I have kind of two comments. One is that there's a message here that self-management is in fact a universally desirable behavior, and not much said about, a little alluding to the fact that maybe people don't really want to do this, but that the healthcare system thinks this is what they should do. So there's a little gap here, I think, in maybe some further exploration about what it is that people really perceive self-management to be, and how and what it is they want that to look like before the injection of interventions on our part to have them adhere or activate self-management when that may not be a particular patient-oriented goal that they have. So that's one observation that I would make. The other is our speaker here on our council person, Michelle's talk earlier, and she showed the picture of that study where individuals with certain GI microbiota the intervention doesn't work for them because there are biological reasons for things not working. So we can't just give everybody CBT and think they're going to improve self-management behavior. So I think there's no biology here, and I feel like there should be some biobehavioral approach to this whole idea of activation.
The other area I think is somewhat missing here, it seems more individualistic, the approach is, and I'd like to see more of the impact of the environment. How does that impact activation? and take that component into consideration.
Thanks.
Yeah, I just wanted to add to also that the part on activation might work with certain populations, and for others, they might take a more passive role. So to study how that activation happens in the different environments and with the different conditions, like might be totally different for HIV versus diabetes. So I think that's critical, and also the culturally tailoring of intervention. And that's where the cultural that Shirley was mentioning, it's really, you have to take that into account, and how activation happens in those environments and with those groups.
Thank you so much. Any other comments?
Just one quick thought. I was thinking maybe those are the mediators or moderators. I'm never sure which it is. But those factors that influence whether patient activation is actually effective and in what conditions. So I was just thinking about kind of a cluster term for that.
But did you pass your dissertation defense?
Before they had those terms.
Thank you. Thanks for the great suggestions. Thank you. So we're moving on to the next one. The next concept is omics-guided biobehavioral interventions for improved health outcomes, a step forward in translation. And this is assigned to Dr. Connolly.
Okay, so I think actually some of the conversation that we were having is a good segue to these thoughts and this concept. So basically the idea here is that, we're looking to harness the wealth of advances in the fields of genomics and other omics, like epigenomics, microbiomics, transcriptomics, all these other omics, and to take those advances and incorporate them into these non-pharmacological interventions that we have been working on to improve health. So the idea here is that when you think about how the field has moved forward in pharmacogenomics, for example, and how we now know that we need that piece of information for certain types of, when we're thinking about pharmacologic interventions, there's many times when we should be thinking about what someone's omic information looks like and incorporating that into what we think they should start with, how much of it we think they should start with, and then to try and increase effectiveness and decrease side effects, right? So the idea here is that we're bringing this forward for non-pharmacologic interventions. So things like diet interventions, cognitive behavioral therapy, exercise, things of this nature that haven't received as much attention from the idea of being able to say, hey, not everybody responds to exercise the same way. Not everyone responds to CBT the same way. If we had a menu of choices for our, patients, what would we choose for them based on a lot of information, of which omics would be some of that information? So, I think if you think back to when a lot of the pharma companies were thinking about, hey, I put a lot of money into developing this drug, but it didn't work. We tested it, put a lot of money into it, we're going to shelve it because, we're just not seeing it won't be a big enough bang for our buck, so we table it. But then when you start to pull it back off the shelf and think, there are people that this could work for. It just wasn't when we lumped everybody together and treated everybody the same way. So the idea here would be, there's interventions that folks have tried that are non-pharmacological that in the end you thought it didn't work. But maybe it's because we didn't take into account some of the important variables, whether they be behavioral, whether they be biologic, whether they be clinical. But are there variables that we could bring into our evaluation of these interventions that we haven't previously done. So I feel like this concept proposal raises that awareness and says for those folks who are thinking about developing the evidence for an intervention or thinking about conducting an intervention study, that you give some thought to incorporating some of these biologic pieces, and I think not only does it raise awareness and encourages that sort of inclusion, but also that it's incredibly timely. That is a timely concept. And it does hit many of NINR's strategic plan areas like omics, symptom science, self-management, and wellness. I would also put a shout out for the fact that, if you think that behavior variability is impacting response to your non-pharmacologic intervention, and you don't take biology into account, you could miss your behavioral pieces. And vice versa. You could miss your biologic pieces if you don't take your behavioral pieces into account. So I would advocate that we have, that we strengthen the concept a little bit more around marrying these concepts. But some of the objectives that were raised, I think, are very good, and then I have a couple of additional ones to think about. So some of the objectives that were put forth would be things like expand or refine mechanistic studies so that we have the evidence to incorporate those omic markers, and then developing non-pharma interventions that incorporate these omic markers, and then performing early testing of omics-guided non-pharma interventions via things like phase 1 and phase 2 clinical trials. I would also add that if folks had the forethought to bank samples on participants on which they did intervention studies, and I think a lot of people were encouraged to do that, that isn't captured by these objectives, that I would add an objective that would encourage folks to pull your stuff out of the freezer and put it to work here. And then also to maybe have an objective that's around use of existing data. So having people go out to see what's in dbGaP, what's in GEO, what are in these publicly available databases that we know we have phenotype data, we have clinical data, we have demographic data, we have omics data already, but maybe you don't have the encouragement or the funding to actually go out and harness those resources, that maybe there could be an objective built in here to encourage people to use some existing resources that are already out there that could help answer some of these important questions as well. So those were my thoughts.
Thank you so much, Dr. Connolly. Yeah.
Well, I really like those last ideas because I'm sitting here thinking about how expensive it is to get these biological samples and to include all that in the course of an ongoing study when you're not sure that the markers are even related to the things that you're trying to study is, well, it's certainly doable, we do it, but to take advantage of some of what is already existing in data sets, or as you say, in the freezer, that we could look at and make some decisions about which sorts of markers should we use, because, frankly, these genetic tests are very expensive. So before we go down a path and a wide open qualitative view of what's out there that might work, it would be nice to have a little bit of at least empirical evidence of things that do work based on data that we already have. That'd be great.
What I'm hearing is that a lot of that would be kind of a secondary analysis. And, we just don't have mechanisms to do secondary analysis, all right? Especially ones that would take that kind of money. And it's not huge money, but nevertheless, it takes some money to pull them out of the freezer, get them analyzed, and do that. And I think it's a problem in our whole funding pipeline systems that we have of how we get money to analyze our samples, those of us who did collect them, and hope that it's the right tube and the right amount and the right color thing, I mean, all that kind of stuff. But I just point out this issue that I think is it could be impeding some of that.
You think of all the intervention trials of non-pharmacological interventions that have been done, where you get to the end and you spend lots of money, and then it turned out it didn't work. I know I've had my share, and that's kind of the end of the line. And what a waste that is to get to that point, when in fact by thoughtfully collecting data, particularly on biomarkers, and having it there. Maybe there are mechanisms that could be used, maybe supplements, for example, to add things to studies to be able to collect that data, so you don't get to the end of a line of a behavioral intervention that didn't work and you say, well, I have nothing to say. Maybe we can be more clever and start building up ways to reach better conclusions. Thinking of Dr. Macy's presentation, you didn't see any differences between in the hippocampus of males and females until you thought to look at them separately, and then suddenly everything was there. Same way, I suspect, with many of our interventions, and I think it's worth it.
Our CTSI, and I think many others across the country, the translational institutes that are funded, there are over 60 now, I believe, but a lot of them do biobanking across institutions, and that might be something to consider in terms of existing resources that have large biologic data, but they also are moving, some of them have already moved towards linking some of that with data from the electronic medical records, which then could be a resource. And they may give, at least to start, they may be giving pilot money for studies using these banks. That's what I'm hearing in my university.
One additional thought that I thought of when we're talking about pulling samples out of the freezers, if you consented your participants in your intervention study to be recontacted, you can't do every omics approach by going back and getting a sample from them later on, but certainly if you wanted to do a polymorphism-based study, that doesn't change over time, just like what all of us are doing. You could go back and collect those samples and actually now collect new data that you overlay on top of your intervention if you did indeed get permission to go back and recontact those folks. So that's another potential way of moving some of this forward without having to have a brand new intervention study per se.
I do want to say I like the idea of this. I think it needs maybe a little bit of fleshing out, but I like the idea of this because I think we, as nurse scientists, have looked for a long time, I think, for some objective, if you will, ways in which to demonstrate the effectiveness of some of our interventions, and this is certainly an avenue that would enable that to happen. So I'm supportive. I like the idea. I think there's been some good discussion here about it.
It's a good nudge.
Thank you so much. Thanks. And the last concept is strategies to improve health outcomes and to reduce disparities in rural populations. And this is assigned to Dr. Fletcher.
So this concept, in my opinion, is very well written, and I'm in full support. It supports the strategic plan of NACNR areas of wellness and self-management, and the goal is to have telehealth, telemedicine access for rural populations. The concept, the author documents really well that in rural areas, the people of rural areas have or die most readily from heart disease, cancer, accidental injuries, chronic lower respiratory diseases, and stroke. And it says, or the rationale for this concept is needed to advance the science around and increase the adoption of interventions to reduce the health risks faced by rural Americans. Being from a rural state of Mississippi and having done work with the University of Mississippi Medical Center and having been designated by HRSA, the University of Mississippi Medical Center is one of 2 telehealth centers of excellence in the United States. So this is very appropriate, it's timely. I think the concept is needed. As far as the impact, it will garner a greater understanding of the challenges faced by rural population groups. It will address social determinants of rural population health, culturally relevant research approaches, and implementable interventions. The only thing or the only suggestion or comment that I did observe is it's not really clear the interprofessional collaboration, especially the advanced practice registered nurse role. I think it's presumed that it's medical, but I think the advanced practice registered nurse and or the interprofessional collaboration could be brought out a little bit better.
Thank you so much. So open for discussion.
I don't know the facts about this, but just listening to the general news, isn't addiction a huge problem in rural areas? And I wondered if that could be placed in here as an example of a focus area for this type of work.
I was wondering about the subpopulations within rural health. I worry sometimes when we just see this rural health and then we go out and I live in an area where there's a large Amish community. I mean, I think it's the second largest in the United States. And to link that group just when we go out with others, and especially if we're recruiting in acute care because they seek acute care very rapidly, but then they just get in your sample and they're really very different. And there's probably other, I use that just as an example, to remember the diversity within the rural populations there.
So, you mentioned being a telehealth center of excellence, and I didn't see that here, and I wonder if that's not a great thing to capitalize on, especially given the sort of technology focus of NACNR, that how does that enhance sort of the health outcomes within a rural population as well?
Yeah, I wanted to add that, what was mentioned before, I think mental health, opioids, they're happening in these rural communities, but also, the access to care, the telehealth, that would be a way to get to those communities, but who provides care is what you were mentioning, are the advanced, the nurse practitioners are usually in those areas. There are not many physician to patient community ratios. So one has to look at that team approach and how, to do it with the person providing the access to care in those communities. And the very important point that rural, like Shirley was saying, it's not like everybody the same. There are very different populations like, Native American Indians, there's a lot of different populations in those rural areas.
I was thinking now migrant workers too.
Also too, huge.
Very different from long-term farm owners populations.
Important, and you have captured the use of community-based participatory research approaches. Because regardless of what community you're working with, if you're designing or adapting an intervention, using that type of approach, and there's bi-directional knowledge sharing between the community and the research team, it's going to positively impact the design of the study and what you deliver, as well as in the evaluation. It needs to be in that piece as well.
Well, so thank you so much for your feedback on all the concepts, and we'll take all this into consideration. We'll go to the next steps. Thank you.
Thank you very much. That ends day 1 of council. Day 2 begins at 9 a.m. tomorrow morning. I believe it's the same location. Same location. Is there anything else that we need to announce? No, I'm being told. Okay, in that case, day 1 is closed.